Hello, and welcome to the Sarcoma Foundation of America's panel discussion, Immunotherapy Advances in Sarcoma. My name is Dean Freilich, and I'm the Director of Scientific Affairs at SFA. We are glad that you have joined us for what promises to be a very informative session. Before we begin, I'd like to briefly go over the format and logistical details of this webinar. I will be serving as the moderator for today's session. We have 4 panelists who will give a brief background on the immune system and what cancer immunotherapy is, an overview of current cancer-wide immunotherapies, promising current immunotherapy treatments specific to sarcoma, and where the future of immunotherapy in sarcoma is headed. After their presentations, we will have a question and answer session. I will ask the panelists questions submitted by participants. At any time during today's session, you can submit your questions by entering them in the questions field. Our panelists will not be able to answer questions related to your specific medical situation, so please make sure that they are related to the topics raised during the session. The information contained in this webinar is intended to be for educational and informational purposes only. It is not a substitute for medical advice from your physician about your specific situation. Today's session is being recorded. The discussion will be archived and a link will be posted to SFA's website. Lastly, as a reminder, all participants are muted and any questions or comments can be submitted through the webinar's question portal. An important part of our mission at the Sarcoma Foundation of America is to provide educational opportunities to help empower the sarcoma community. Now, I would like to introduce our panel members. Dr. Seth Pollack is the director of the sarcoma program, Lurie Cancer Center at Northwestern University Feinberg School of Medicine. Dr. Pollack's focus is on immunotherapy and in particular CAR T-cell therapy, as well as targeted therapy in sarcoma. Dr. Evan Rosenbaum is an assistant attending in sarcoma medical oncology at Memorial Sloan Kettering Cancer Center. Dr. Rosenbaum's research interests include modulating the immune system to help identify and fight tumors and to exploit the molecular characteristics of sarcomas with targeted therapies. Dr. Breland Wilky is Associate Professor and Director of Sarcoma Medical Oncology at the University of Colorado Anschutz Medical Campus. Dr. Wilky specializes in all kinds of bone and soft tissue tumors and cancers. She is active in clinical trials, including immunotherapy and personalized precision medicine. Dr. Brian Van Tine is a Professor of Medicine and Pediatrics and the Sarcoma Program Director at the Siteman Cancer Center at Washington University in St. Louis. In addition to research immunotherapy, Dr. Van Tine focuses on the study of the genomics and genetics of bone and soft tissue sarcomas, working to identify the druggable driving pathways for treatment of sarcomas. Again, thank you to the panelists for joining us today. I will now hand it off to Dr. Pollack, who will provide the first presentation. Dr. Pollack?
Thanks. Yeah, it's such a pleasure to be here, and I can't believe we have so many attendees. It's really encouraging to see what kind of amazing interest there is in immunotherapy for sarcoma. Can everyone, can you see my slides okay?
Yes.
Mm-hmm. So, I want to just, really, I've been asked to talk about what is immunotherapy, and it sounds like a simple question, but it's actually a really complicated question, because immunotherapy can be so many different things, and we'll talk about the variety of different treatments that we consider immunotherapy. And we'll also probably talk about some treatments where I think it's controversial whether they're considered to be immunotherapy. To me, immunotherapy, it comes down to, fundamentally a way that we're distinguishing cancer from the rest of the body. And that's really kind of at the heart of everything that we do in oncology and cancer treatments. We give a patient chemotherapy, what that is usually doing in sort of a simplified way is separating the rapidly dividing cells from the non-rapidly dividing cells. And that winds up depleting the healthy rapidly dividing cells, like the cells that make your hair, the cells that make your bone marrow and your blood counts go up. But Usually the fastest growing cells are going to be the cancer, and hopefully the chemotherapy can wipe it out. Radiation and surgery distinguish this by really just looking anatomically. Where's the tumor? Can we kill it? Can we remove it? Molecularly targeted therapies look for a specific change that's happened in the tumor that is changing how the cancer is driven. And can we make a drug that's only going to interfere with that mechanism that's really crucial for the tumor, but isn't crucial for your healthy cells? Your healthy cells can get by even with that molecular pathway blocked. Metabolic therapy, this is becoming a really hot topic, something that Brian actually taught me a lot about. It's something that he's an expert in. How does the tumor use sugar differently from the rest of the body? That's something that a lot of patients are asking me. And I think it's really important. I think it's part of where the future of oncology is going. And then tyrosine kinase inhibitors are sort of like a molecularly targeted kind of strategy that's kind of, using a really fundamental machinery that all cells use, but are sometimes especially important in cancer. So where does immunotherapy fit in with all of this? Immunotherapy is a really specific way that the immune system can recognize the cancer. So one of the most common questions I get about immunotherapy is this immunotherapy. Are these vitamins immunotherapy? Is there some sort of food I can take to boost my immune system? Is there an exercise I can do to boost my immune system? If I could do these things, maybe my immune system would just be stronger and I could fight my cancer. And it's really important. It's really important to have a healthy diet. It's really important to exercise. I think these things are so important. And I think that supplements and vitamins, I think they can be helpful as well. But there's no magic supplements that's going to make your immune system really fight the cancer. And when I talk about immunotherapy, I don't mean these sorts of things. I don't mean supplements. I don't mean nutrition. I don't mean exercise, because I'm talking about something that's very specific in distinguishing the cancer from the rest of your body. I'm not just talking about making your healthy body stronger. I'm talking about really how do we distinguish the cancer from the healthy tissues in the body in a way that we can give your whole body a drug that's going to kill the cancer and not kill your healthy body. So there's there's a lot of different cells that are in the immune system, right? There's a ton of cells, actually. There's one cell called natural killer cells. You might hear about those. They're becoming a little bit more in vogue as a way of using immunotherapy. There are dendritic cells, there are macrophages. These are all important parts of the immune system. But the two cells that I think are really driving most of the immunotherapies that you'll hear about are B cells and T cells. What do these cells do? Well, the B cells, they make antibodies, and everybody knows about antibodies these days because antibodies are important for fighting viruses. They're how you get your immunity after you get your COVID vaccine and all your other vaccinations that you might get. And we have antibodies that we use for fighting cancer. And in sarcoma, we don't use so many of them, but you may know somebody with breast cancer who received a drug called Herceptin, right? That's an antibody that directly attacks the cancer. Is that immunotherapy? That's kind of I consider that to be immunotherapy, because you're taking you're using the immune system to fight the cancer. You're using something derived from the immune system. It's a little bit controversial because these days using, it's almost, we almost forget about the fact that these drugs come from B cells, but they do. But what's very relevant now is, Evan's going to talk, I think, in a minute about PD-1 inhibitors, and those are an antibody that we're using to rev up the immune system. Now, T cells are really at the heart of modern immunotherapy. These are the cells in your body that are most important for the natural response against cancer. Just like, and these are the cells that are altered when you hear about gene engineered T cells to have new specificity to recognize the cancer. Now, how can the immune system, whether it's the B cells or the T cells, tell what's cancer and what's healthy tissue? Well, there's two ways. One, and this is probably the most common way, like in the natural setting, is that the cancer will have a mutated protein, and the T cells are scouring, looking for abnormal proteins that should not be in the body. A mutated protein should not be anywhere in the body, just like a viral protein should not be anywhere in the body. And these T cells, they've evolved to detect viruses. And just like they go around scouring the body for viral proteins, they're also on the lookout for mutated proteins. And that's actually probably the most common type of target that's being recognized when you hear about checkpoint inhibitors like Optivo, like Keytruda, like Yervoy. Now, the other type of common target that the immune system can recognize are abnormally expressed proteins. And what these usually are, and these are the ones that you may have heard about in the NY-ESO-1 or MAGE-4 trials for synovial sarcoma. These are proteins that are expressed in tissues, in healthy tissues that the immune system shouldn't see. And the most common one that we hear about are the spermatogonia of the testis. These are the cells that become sperm. And eventually these proteins are also seen in fetal organs, but your T cells should not go anywhere near these sorts of tissues. So they're actually, those proteins are actually perceived as foreign. And you can see here, this is a slide showing the tubules taking these primitive sperm around the testis, and you can see the same protein is seen in this cancer on the lower slide. Finally, I want to talk about, I think Evan's going to go a little bit more into detail about this, but the way this plays out is that you have T cells that are in the tumor, and I know this is kind of a complicated picture, but it's basically showing that the tumor, we used to think about the tumor as just being like a block of tumor cells, but actually it's a really complicated network of tumor cells, and then all the other immune cells that are inside the tumor, the macrophages that we were talking about before, B cells and T cells. And some of the immunotherapies that we're using are going to try and help those T cells that are already in the tumor trying to fight the cancer work harder and work better. And then the other side of things is trying to redirect T cells that are healthy and give them new specificity so that they're seeing tumor cells that they may not have seen before. That's gene engineering T cells. So taking T cells from the blood of patients, gene engineering them so that they have a new specificity, and then infusing them back into their patients. So that is my very brief overview of the immune system, and I'll pass the baton.
Thank you, Seth. Sorry, I'm going to pull up my presentation now. Sorry for that delay. Can everyone see the slides here?
Yes, we can.
Great. So thank you again to the Sarcoma Foundation of America for allowing me to join this panel today, and for my co-panelists for their insight. And thanks, Seth, for setting the stage here. I think you made a really important point about what is and what is not immunotherapy, because a lot of our drugs do modulate the immune system in one way or another. Even traditional chemotherapy does. And where I chose to draw the line for what I'm focusing on today is somewhat subjective. So I just want to point that out. But I am going to talk about where we stand today in terms of quote unquote immunotherapies that we've been alluding to, which drugs have been FDA approved to date, from way back when, decades ago, to just months ago, actually. And I just want to also say that I'm not going to talk about individual clinical trial data and which drug, what exactly prolongs survival or progression-free survival or overall survival or any numbers. I'm really focusing on the mechanism, how these drugs work, how they modulate the immune system, and what can we learn from them moving forward. And I want to talk about a category of immunotherapies depending on the modality or the mechanism that we use to basically change the immune system. So if the middle of this slide here represents the tumor and its microenvironment that Seth had alluded to on one of his slides, with the pink cells here representing the tumor and the smaller colorful cells representing the immune system, all these different immune cells that are trying to infiltrate and attack the tumor. We are trying to augment that response to make it better. And there are numerous ways of doing it. And I'm going to quickly highlight some types of cytokines that have been used. These are cellular signals that are secreted by the immune system that has been used to treat cancer. Some vaccines that are trying to prevent the cancer from regrowing in the body once it's removed. I'm going to talk about immune checkpoint inhibitors that Seth alluded to already. Some infectious agents that can also stimulate the immune system. Adoptive cell transfer. These are the genetically engineered cells that Seth was talking about. And lastly, introduce a group of drugs called bispecific engagers. These are engineered molecules that try to bring the immune system and the tumor into close proximity with one another. So let's start with cancer vaccines. This has been somewhat of a holy grail for scientists over the past many decades. Obviously, we're all familiar with vaccine development over the past few years in COVID, and we know that there are many ways to make a vaccine. There's no one size fits all. And scientists and cancer investigators have been looking at many different types of vaccines for cancer. There certainly will not be a one size fits all, but this is one type of vaccine, if you will, that has been approved by the FDA. It's called Sipuleucel T, and it's approved for patients with advanced prostate cancer. And the way this drug is developed is white blood cells are removed from the patient. These white blood cells are incubated with a particular protein that resembles a prostate cancer that sensitizes these white blood cells to what the prostate cancer should look like in the body. These cells are then reinfused into the patient. And this is a real drug, and it has received approval by the FDA because it does prolong survival compared to patients who receive a control drug. So it really does work in priming the immune system. It's not a frequently used drug to the best of my knowledge compared to other prostate cancer drugs for multiple reasons that we're not going to get into today, but it's proof of principle that we can sensitize the immune system. And so there are many studies ongoing looking at novel types of vaccines. Shifting gears to the cytokines, the cellular signals. So these are signals that are secreted by both our healthy cells in our bodies, probably sometimes also cancer cells, and as well as the immune system when it's seeing the cancer cell. And there's a balance in these cytokines. Some of them try to activate the immune system. Some of them try to shut down the immune system. And scientists, this is decades ago already, have tried to take the ones that are thought to activate the immune system, infuse them directly into the patient, and try to induce anti-cancer response. And they have seen success. So this drug, interferon alpha, was approved, for example, in melanoma. Patients who have their melanoma taken out by surgery and are given this drug by infusion, they do tend to live longer than those who did not get the drug in some trials, which led to the FDA approval. Also proof of principle that we can modulate the immune system. These drugs have been replaced by some of the newer immunotherapy drugs that I'll talk about shortly. Very similarly, a drug called interleukin-2 or IL-2 for short, another what we think about as a T cell growth factor. It can, if you incubate it along with T cells, it can stimulate them and activate them. And patients with kidney cancer and melanoma, a subset of them in clinical trials had really remarkable responses. Again, proof of principle that the immune system is probably responsible for control of cancer. And there usually at some point there's something blocking it. And when we give these IL-2 drugs, we can actually overcome whatever blockage that exists. Again, this drug has also been supplanted by newer therapies in melanoma and kidney cancer. So switching gears to the infectious agents that I had alluded to before. And this is, again, maybe reframes how we think about immunotherapy, but this is an old drug as well. It's a bacteria related to tuberculosis that is actually also used as a vaccine for tuberculosis in some developing countries. This drug, Bacillus calmette-guerin, or BCG for short, is approved for patients who have superficial bladder cancer that has been successfully removed with surgery. The urologist can infuse this into the bladder after their surgery and to try to prevent recurrence. And we think this works in multiple ways. One way by directly potentially attacking the bladder cancer cells that may be left over, but also by inducing the immune system by sort of revving it up, if you will, and allowing it to identify something that's foreign. So it identifies both this bacterium and also the cancer cells. Another approach, which doesn't use bacteria, instead it uses viruses, is a category we call oncolytic viruses. These are genetically modified viruses that are adapted to be injected directly into a tumor and to cause very similar damage to what I mentioned earlier with the BCG, to either kill the cancer cells directly or stimulate the immune system to attack the cancer. This is FDA approved specifically in melanoma back in 2015. Since then, it's been studied in combination with some novel immunotherapies, which I'll talk about now. Checkpoint inhibitors. This has probably been the biggest revolution in cancer immunotherapy. It's a big statement to make, but I mean, in terms of FDA approvals, there are many cancers, probably a dozen, that have an approval for one of these drugs. And the way they work, if you focus on the figure on the right, with these two colors, the red and blue, CTLA-4 and PD-1, these are essentially brakes to the immune system that generally function to suppress the immune system and not allow it to try to fight cancer. If we can turn off the brake and block its action, then we can let the immune system recognize the cancer and go about doing its job to eradicate it. This was first studied, this first drug, Yervoy, or ipilimumab as the generic name, was approved in 2011 to be used alone in patients with melanoma. Since then, has been approved in combination with the drug on our next slide, which I'll get to in a second. But really, we have seen remarkable responses in many different cancers. And obviously, we're very keen to try to mimic these remarkable responses in sarcoma patients. The next drug, which is very similar to Yervoy, except that it blocks a different protein. Instead of blocking the CTLA-4, like ipilimumab, it blocks PD-1. And there's another drug you may have heard of called nivolumab, which works exactly the same way, also blocks PD-1. These have been approved in more cancers than ipilimumab has been, sometimes alone, sometimes in combination with a CTLA-4 blocker. Again, cutting the brakes and unleashing the immune system's predominantly T cell response, we think, against the cancer. The hot off the press is another immune checkpoint that was recently approved. And this is yet another protein on the surface of the T cells that is responsible, we think, for stopping the T cell from acting against the cancer. And a recent study showed that if this drug, relatlimab, is given in combination with nivolumab, the PD-1 drug, patients with melanoma who have advanced melanoma respond better if they get both of these drugs rather than getting nivolumab alone. And I think this is a really exciting for the field because it shows that this immunotherapy, this immune checkpoint inhibition is not limited to PD-1 or CTLA-4, but there are many other immune checkpoints that are potentially ripe for exploitation. And I have two more, I believe, categories left. One is the bispecific engagers. This is a really intuitive category of treatments, I think. And the way it works is it's sort of like if you look on the cartoon on the right here, it's like a grappling hook. One side of the grappling hook will hold on to the T cell, the immune cell, and the other side will hold on to the cancer, and it brings them in close proximity in the hopes that the immune cell will then recognize this cancer cell and begin to try to kill it. This drug in particular, called blinatumomab, was approved a few years ago in acute lymphoblastic leukemia that has relapsed. And there is another recent approval of a similar but different drug in patients who have a very particular type of melanoma called uveal melanoma that arises in the eye. And this drug, called tebentafusp, is a slightly different as an engineering protein wise than the other one. But what's nice about it in theory is that it can recognize some proteins that are on the inside of the cell that are then brought to the outside. So I think the takeaway about this drug is that there may be many more forms of proteins that can be targeted, for example, in solid tumors as well, and that's pretty exciting. And then the last category that I'm going to touch upon are the engineered T cells or CAR T cells, depending on what drug specifically we're referring to. CAR stands for chimeric antigen receptor T cell. And this is just one example of one drug. There are numerous that have been approved, mostly in liquid malignancies or leukemia, lymphoma. And the way this drug works is similar to the vaccine that I mentioned. The white blood cells are removed from the patient prior to treatment. These white blood cells are then engineered in order to attack a very particular target on the cancer and then reinfused into the patient. And the responses that have been reported to date have been extremely groundbreaking and very exciting for the field of cancer. And there's a lot of interest ongoing in bringing this to solid tumors like sarcoma and others. And I'm going to wrap it up here and leave it to the next panelist to talk about sarcoma in particular.
Great. Thanks so much, Evan. Let me just try to share my screen. Again, thanks to the organizers for the invitation to be here with this distinguished panel. And I'm always happy to chat about immunotherapy, my favorite things. So I'm going to summarize these really amazing talks that we've just heard and sort of get this really granular for us as we start to think about how we can approach sarcoma. How can we use some of these technologies to actually help fight these cancers, the cancers that we're all dealing with on a daily basis. So this is yet another cartoon that just, I'm going to sort of emphasize the high points again. But in order for your immune system to recognize and kill a sarcoma cell, there have to be multiple steps that happen. There's got to be something about the sarcoma that's foreign that it can recognize. That's called an antigen. The antigens have to be recognized by those immune reporter cells, if you will. So that's your macrophages or dendritic cells that that Dr. Pollack was talking about. And then those policeman cells have to go back and they have to educate the super duty T cells. Okay. And so this process of activating and priming and educating depends a lot on that protein CTLA-4, which is one of the targets that has been looked at with these checkpoint inhibitors. Okay. And then there's always the yin and yang. There's very activated antigen cells or macrophages and dendritic cells, and then there's very suppressive cells. So there has to be the right balance for all of this to happen. Without tumor-specific T cells, so T cells that are specific for sarcoma, the rest of the steps in this process become very, very difficult to accomplish anything. So one way to get around that is to build your own tumor-specific T cells, which is what people were just talking about with adoptive cellular therapy, and we'll mention that as well. But assuming all of these steps were successful, you have to be able to get those T cells into the tumor. They have to get face-to-face with the tumor cell, and there has to be able to be a kill. There has to be a recognition of a threat, literally head-to-head, so that the T cell can then kill the cancer cell. And that's where some of these other checkpoint proteins block things. So that's the PD-1 part, is right at the tail end. So again, in a nutshell, if we don't have our T cells, and it doesn't really matter whether we turn them on with PD-1 blockers, you have to be able to generate them first. So what we know about sarcomas in general is that a lot of them, about 80% of them, are kind of not so great at triggering the immune system at the very beginning, okay? And this is called a lack of immunogenicity, or basically the sarcoma just looks like normal cells and is a really, really lousy at triggering a response by our own immune cells. And so when I get into some of the trials and the treatments that I think are exciting, a lot of our efforts right now are focused early on at trying to make the sarcoma cells look more foreign. And some of the best ways to do that include chemotherapy, radiation treatment can do it as well, and then cytokines. We are blocking CTLA-4, which can help, again, with the priming. We'll talk about adoptive cellular therapies, identifying the targets that we do know and where we can be studying these. And then there's a bunch of efforts going on to use medications to help make the microenvironment. So what that means is, can we help the T cells or the immune cells function better in the tumor bed? And that can be focused on getting more blood flow into the tumors. That can change metabolism to help, that be less angry and less toxic for the poor little T cells that are trying to live and thrive, but they're surrounded by acid and they don't have enough oxygen and all of these other metabolic things. So that's basically the overview of what I'm going to show you now, which are some of the trials that we're actually doing. So this is Wilky's top 10. Now, there are a lot of trials out there, and I only have a few minutes, so I'm not going to be able to hit on everything. But I think if you ask me what are the most exciting directions that we are currently exploring or about to explore for sarcoma, this is it. So many of you may have heard about these engineered T cells. Okay, so these are where we take your own blood cells. You have to be a certain tissue type. You have to have the target that we care about, and the two big ones are NY-ESO-1 and MAGE-A4. Most sarcomas don't have these markers, but synovial sarcoma and myxoid round cell liposarcoma can, and there's a few tiny population of other types of sarcomas that might have these. So hopefully in the future, we're going to be testing this on a lot more people than we are right now. But these look really exciting. The data is shown that you can get responses, meaning that tumors can shrink with these T cells. It's a big investment. There's a lot of side effects. It's a very intensive therapy, and it's not for everyone. But what I'm telling people is if you have synovial, you have myxoid round cell, you definitely want to get tested, at least to know if this is an option for you. So these will likely, hopefully, get approved in the near future for treatment. Number 2, CAR T cells. We've heard a lot about CARs. They're slightly different than the engineered T cells, but again, cellular therapy for a known target. So the ones that are currently being explored include GD2, EGFR, B7H3, and HER2. And primarily, these are our pediatric sarcoma types. So osteo, Ewing sarcoma, rhabdomyosarcoma has been studied, especially with HER2. So there's a few other ones. So again, for the right disease or the right, and where we can test for the targets, this may be something really exciting to look at as well. Next, DR5. What is DR5? Death receptor. Doesn't that sound very Star Wars? Death receptor 5. Okay, so this is an antibody. We heard about antibodies that basically binds to a signal that says die, cell, die. And a lot of sarcomas actually express DR5, and probably the home run, or at least the leading type of sarcoma that looks great for this is chondrosarcoma, or basically the conventional chondrosarcoma, which we've had very few treatments for. So this drug was reported in an early study, sort of an all-comers mishmash, but chondro looked like there was some promising signals, and now a phase 2 study for DR5 from a company called Inhibrx is opened and enrolling. So this is something to keep an eye on as well. Globally, chemotherapy and checkpoints. This is my big thing. This is where I think we're going to make the most progress in the future. And there's a bunch of studies going on right now that we need that data for. So combining checkpoint inhibitors, that's PD-1 and or CTLA-4 direction with doxorubicin, with trabectedin, with eribulin, with gemcitabine and docetaxel, all the main chemo backbones that we use for sarcoma. This is really exciting because, again, I think chemo will boost that initial antigen production, the initial immune response, and hopefully make everything work a little bit better. Same thing, our blood vessel blocking drugs, our tyrosine kinase inhibitors. These are drugs like Votrient or, pazopanib or cabozantinib. These are all drugs that do a lot for the immune system. They change the way, again, that the microenvironment is functioning. And these combinations we've been exploring to some degree, but I think we're still looking for the perfect drug and the right patient at the right time. But several studies going on that look exciting for soft tissue sarcomas. And then there's also been some studies for bone sarcomas in the past as well. All right, TIL therapy. So this is now we're starting to angle a little bit more towards the future. What are TILs? TIL stands for tumor infiltrating lymphocytes. What that means is instead of the CAR Ts or the engineered T cells where you take your own normal immune cells from the blood and then you make them specific for a known target, one known target, TILs are where you take a tumor out and you pull the immune cells out of the tumor. So already you kind of know if they're in the tumor, they should be specific for the tumor. And you don't really care about the target because you could have 300, 400, thousands of T cells in that tumor that already are educated. So you grow them up in the lab, you expand them, and then you give them back to the patient again. So it's sort of a customized treatment. And this has been going on at various places for a while, but there's a couple of trials at Moffitt and MD Anderson that are now doing this for sarcomas. And the future is there for engineering TILs even more. And we're really excited about that here at our institution, a couple years probably down the road, but I think it's going to become the next big frontier for sarcoma. Same thing with natural killer cells, which Dr. Pollack, I think, touched on. Natural killer cells are sort of the opposite of T cells. So when the T cells don't function, meaning there's not the right antigen, oftentimes the natural killers take over. It's, again, a yin and yang. So people have been very interested in natural killers for a long time for sarcoma. There's also these things that are the best of both worlds, which are called natural killer T cells. They've got both features of the two main groups. So you'll see these starting to pop up quite a bit actually in studies. I actually forgot to put the trial number. I can add that when I give you the slides, but there's these tend to be either off the shelf products or from individual patients. You can put CAR constructs in there. So adding a target that you know is specific as well is starting to get looked at. So this is going to be a big wave down the road as well. All right, I'm babbling. Got time to wrap it up. For osteo, check out this trial. This is adenosine blockade, which is, again, another one of these master suppressive nasty things that keeps the tumor microenvironment from the immune system to work properly in it. So this is being run out of MD Anderson. I think is a great study. We heard from Dr. Rosenbaum about a lot of other targets. Okay, somebody asked in the chat, well, why aren't, you're talking about kidney cancer, you're talking about melanoma. Why? It's because we need to learn from those cancers. If we don't really start to look at what other people are doing and learn those lessons, we're always going to be behind. So that's why it's so important to understand what's going on for other tumor types and get patients into those all-comer trials, because that may be the first time where we understand how those agents are going to work. And then last but not least, epigenetics. So these are drugs that reprogram not just one gene, but like the entire genome gets flipped on or flipped off, okay? These are hugely promising for globally increasing the amount of foreignness. And there's going to be a great abstract at the upcoming ASCO meeting looking at some of these mechanisms, just a little plug. So I think this is also going to be a next major frontier. All right, sorry to run so long. I am done. Thanks, everybody.
So my name is Brian Van Tide, and I'm going to probably, just for the sake of questions, keep this a little shorter. But I think it's important that you have to realize as a patient, the people that are on this panel, not me, but Dr. Wilky, Dr. Pollack, and Dr. Rosenbaum have really dedicated their lives to developing immunotherapy for sarcoma. When I first met Seth Pollack, it was at the first ASCO I went to, and he was already talking about NY-ESO, like this was going to transform the treatment of one of the sarcomas, and he was right. Things have come so far in the last 10 years. When I first met Dr. Wilky, she was talking about making TILs, and these are things that are now coming into fruition. And, as Dr. Rosenbaum is coming online with his new ideas, there is a group of sarcoma physicians that have been dedicated to this avenue of treatment for more than a decade. And then if you go back even farther, our predecessors wanted to do this. They had a drug called doxorubicin. And so I can tell you that the treatment for sarcoma in my lifetime has dramatically changed. And so I'm going to take this opportunity because one of the things I would have never thought of 10 years ago is, a T-spear to treat synovial sarcoma. And then all of a sudden you're getting complete responses and people that have to reprogram their lives because all of a sudden they thought they were going to die. And like the hardest conversations we have now are, well, what am I going to do now? I have to come off of disability. So, I think a lot of this is a reflection of what Dr. Wilky just said. But, if we get into the future, I think we just came from AACR Sarcoma in Montreal, where we're starting to see very specific sarcoma signatures for immunotherapy. And this is going all the way down to a specific signature for osteosarcoma, a specific signature for malignant peripheral nerve tissue tumors, and then lots of kind of general soft tissue sarcomas signatures looking at B cells. And I think as a field, we're really beginning to understand this for you. Nothing's as fast as you want it, and really nothing's as fast as I want it, but there is progress. And so I think what we've lived through, started looking at, mono and dual and triple immunotherapies and figuring out who has, the molecular genetics to respond versus who isn't. There is very clear, strong feelings I have of why you don't give Pembro to Ewings, mainly because I was part of the trial and it didn't work. And so I think one of the things you have to realize is there's a partnership. If we find something, please let us test it because we can't get the advances to you without this partnership. I think that one of the neat sets of papers that have come out, a lot from Dr. Pollack's lab and Dr. Wilky's lab, has to do with chemotherapy plus immune checkpoint inhibitors. And a lot of these are now out in clinical cancer research. And what you see is these things actually make, the damage chemo does actually makes the immune system respond better. And so the trials where you see doxorubicin with something or trabectedin with something, et cetera, are much better probably to be, it's always better to be part of a trial because not only do you help yourself, you help everybody else with sarcoma. As you get into VEGF blockades, even I wrote a trial involving VEGF blockades where we partnered with Dr. Wilky and, we're studying cabozantinib because, everybody needs to add something to ipilimumab and nivolumab to potentially make it work better. And out of that'll come more signatures that go around in a circle that tells us what else to put in and what else to do. One of the most exciting things of my career that I've been involved in, which is really based a lot on Seth's work, is the MAGE for, T-spear for synovial sarcoma, the NY-ESO T-spear for myxoid round cell. And then there's GD2, and then now there's one coming for the MUC16. There are a lot of really interesting adaptive cellular therapies and TIL therapies coming. And, which one is for you is really going to become the question. But this is, my view over the next 5 to 10 years. And then, there are other approaches, NK cells, or probably the thing that we haven't thought of is the thing we haven't thought of yet. That which isn't in clinic, that's which is in somebody's laboratory, that is which is what is coming. And only with a partnership between us, you, and industry can we actually push for the 170 different kinds of sarcomas that are not going to be treated the same way when it comes to eradicating them by getting the immune system to finally clear the tumors that aren't really part of us, but right now our immune systems think are part of this. And so while I appreciate being included in this, it's really it's an honor to be with the people whose real focus is doing this. And so with that, I'll turn it back over so we can have some semblance of a discussion.
Thank you, everyone, and thanks for your discussions and insights. We do have a few questions. First of all, we'd like to, so one question is, for T-cell therapies trials, is it accurate that you have to test positive for the gene of interest that you had mentioned?
So there's two things that you need to test for if you want to go on a T-cell trial. I mean, of course, you have to have all the other things that you need to do going into a trial. You have to be fit. You have to have good liver function, good kidney function. But there's two real things that you need to have. Okay, so you need to have the protein expressed in the tumor, and that is usually NY-ESO-1 or MAGE-A4. If you're talking about these synovial sarcoma trials, on some of the other trials that Bree was talking about, B7H3, you have to test that your tumor has the target. Now, the second thing is only applicable to some of the most common trials. So Bree also meant, she separated them out like perfectly, like that there are the trials of what we call T-cell receptors, and then there's the trials of the CARs. And if you're talking about a trial of a CAR, and these are still kind of in their infancy, but those are not restricted to any HLA type. But if you are talking about one of the trials that you may have heard about, that you may have known people that have gone on, the NY-ESO-1 trial, the MAGE-A4 trial, you need to test to have this. It's a gene called AO201. Everybody has an HLA type. It's the same thing that you'd match for if you were going to get a bone marrow transplant. Like you've heard of, somebody needs a bone marrow transplant and they are looking for a match. So when you are looking for a match for a bone marrow transplant, there's 6 things that you have to match, and HLA-A is one of them. And this is just one of those things that you need to match for, HLA-AO201. Why HLA-AO201? Why this thing in the bone marrow transplants that, none of the, why not another one? Because this one is frankly more common, and it's still rare. It's still rare. So, they'll tell you 20 to 30% of people have HLA-AO201, but I can tell you in Seattle, it was 15% of the population had AO201. I think it's less than that in Chicago. But that's still by far the most common HLA type, HLA for this sort of HLA. It's the most common. So the next most common is HLA-A24, and you can make NY-ESO-1 specific T cells with HLA-A24. My lab's done it. So, and I know there are companies that have T cells that will work for A24, but they are waiting for the current generation to kind of prove that they can get FDA approval and move into the clinic before they're going to go to sort of the next round. And that'll take a while. I mean, that'll take years before that happens.
So the next question is there any research ongoing concerning why immunotherapy works for some but not others?
Yeah, I can take that one. So that's the $1 million question, right? And so it's incredibly complicated. I mean, you've seen like all of these overviews of the immune system. I mean, it's absolutely crazy, like how many different things affect our ability to mount an immune response or not. And we're trying to learn as much as we can, but the only way to learn is you have to study the patients who get treated. And these are small trials, like we haven't done big trials yet. So you have to study everything about those patients. So you learn every single thing, every cell, every cytokine, you name it, the genetics. You've got to really, really profile those patients. And then you have to go back and build stuff in the lab, right? So you have to use mice that have immune systems, and it's not perfect. There's only a few mouse models out there that you can test this kind of stuff to test immune therapy. But we need to be vigorous and we need to work together, and we need to start building these databases so that we can literally compile massive amounts of data and then use a brilliant robot somewhere to try to start making it fit together and developing more of these signatures that Dr. Van Tine was talking about, and being able to mix and match and say, okay, we're going to profile your tumor and it says this, this, and this, and you've got this HLA and you've got this type of blood going on. So you should do this, right? Or you're going to be resistant because of this, this, and this. And so that's exactly what we need to do the next 20 years, I think. But it's a lot to do and it's very complicated. But yes, everybody on this call is totally obsessed with figuring this out. And that's what we're going to do.
Awesome. Thank you very much. So next, there are other cancers that have some literature with proposing repurposed medications. Where is the sarcoma field with that?
So are you talking more like repurposed drugs for sarcoma treatment or for like immune therapy?
Both. I think if you can speak to both, that would be great.
Well, I will just say that, that we were very grateful in my lab to be funded by SFA actually to do a drug screen doing exactly that, where we basically had 2,500 approved drugs for a bunch of random things, everything from bipolar disorder to antibiotics to arthritis medications. And we are actually studying the effects of those drugs on the immune system. It's turned out to be quite a bit bigger of a project than we anticipated, but that's exactly what we're trying to do, is find the needle in the haystack, some drug that could be used for something else to boost immune responses. I don't know if any of the rest of you want to comment on the more general repurposing.
A little confused by what they're asking in terms of repurposing, because at least as a phase 1 director, repurposing would be to take like the sartan and then bring that into osteosarcoma. And these things are going on. Whereas if you're asking if we're going to take the new LAG-3 inhibitor into sarcoma, of course we're doing it. We would just work first. And so usually drug repurposing to me is taking a drug that's actually not from cancer and repurposing it. Do you take some of the new, LSD inhibitors and bring them in, et cetera, or LSD activators. And so, I think that this is all going on. I think it becomes a question of finances and priority in terms of whether or not we think they're going to be a major hit or a minor hit. And so, there are studies going on left and right, but I think that a lot of the repurposing comes out of non-cancer drugs is slower because we're rare. But at the same point, we've repurposed, ipilimumab and nivolumab from melanoma already. So I want to make sure I'm trying to answer the spirit of the question, but I'm talking out of both sides of my mouth, which is it is going on, but a lot of it is normal.
Thank you very much. So another question is, has there been any progress made in immunotherapy for synovial sarcoma that is not HLA-2 positive?
I would love to jump in here. I think there is a number of really neat things going on in synovial sarcoma. I think one of the things that's out there now in trial from 2 different companies, both Foghorn and C4, is a BRD9 degrader for synovial sarcoma. That's not HLA restricted. It's also not an immunotherapy, but it actually goes right after what the translocation in synovial sarcoma does to rewire the cell. And so there's an oral version, there's an IV version. That's exciting. We just published a paper on ACXT3102, which looks like it's going to work in synovial sarcoma. That's going to a phase 1 trial. There's a lot going on in synovial sarcoma. It's for some reason one of the hotter sarcomas for having a drug hit. And so I think there's exciting opportunities coming up within a year. But like with C4, the first 3 patients, as was just put out on a press release, were just treated. And I know Foghorn's been going on for a while, according to Facebook.
Yeah, I'll just jump in and mention, I still haven't given up on cancer vaccines for synovial sarcoma. This is something that, has been around a while, using NY-ESO-1, MAGE-A4, any of the cancer testis antigens, even using the translocation itself as the target of a vaccine. A lot of you guys may have heard about the big immune design vaccine that in the end didn't pan out, although there were sure flashes of potential greatness there. There were definitely some patients that I have no doubt in my mind benefited on that trial. In fact, there's one patient who had terrible disease, very refractory disease that had a complete response on the vaccine that's still disease-free today, many years later. So I think it's a matter of trying to harness that. How do you get these vaccines to work better? And there are some vaccine trials for synovial out today. There's a phase 1/2. It's still in the phase 1 stage of a cellular vaccine for NY-ESO-1 that's enrolling synovials among other patients. Right now, there's a wait list for it because it's in the dose escalation phase, but there will be a expansion arm for synovial sarcoma and myxoid round cell liposarcoma. So I'm still a believer in that. And then I think the other thing that has always kind of puzzled me about synovial sarcoma is that NY-ESO-1 and MAGE-A4, these are immunogenic proteins. They spark a natural immune response. That's why a vaccine can work. That's why we're able to generate these T cell receptors against them. But for whatever reason, they avoid immune detection. So somebody asked in the chat, what's a cold tumor? And a cold tumor is a tumor that has very few T cells inside of it, that has very few markers on the cell surface that can be recognized by T cells. And synovial sarcoma is a cold tumor. And for whatever reason, even though it has these very immunogenic proteins, the T cells seem to walk right by it without giving it a second look. We've tried to overcome that in the past using a drug called interferon gamma, but that didn't work. And we actually have some ideas about why it might not have worked that we're kind of fleshing out right now. But that's what I would say about that.
If I could add one thing, I mean, from the SARC-028 trial, and this is just pembrolizumab monotherapy, if I'm not mistaken, there was a response in synovial sarcoma. Most patients did not respond, but one patient did, and we still don't know exactly why that is, right? So if we dig deeper into what Bree mentioned before and try to find that biomarker, the elusive biomarker, right, then maybe one drug won't work for all synovial sarcoma patients, but we can find a drug tailored to each synovial sarcoma patient.
Yeah, it's not good. I don't think it's going to be just one. I do not. I think we're going to have a cluster. We're going to have signatures. We're going to have maybe multiple different things that we have to figure out. There's no way we're going to get lucky enough to where, we just test for PD-L1 and that's your go. It's not. Or if we do that, we have to be ready to sort of back it up with combinations and get a whole heck of a lot more detailed. But honestly, if any of you guys know when it works, it's unbelievable. And we have seen people do so incredibly well that we've never been able to see with our more traditional drugs, or at least we rarely do. So I think it's worth doing this, and it's worth digging in and trying to figure this out. There's a couple of questions about like toxicity. So we didn't really talk about side effects of immunotherapy. It's important, but it's a big topic. So I'm happy maybe for a follow-up webinar or something, we can kind of get into that more. But in a nutshell, you're turning your immune system on full blast, and sometimes it gets confused and starts attacking your normal cells as well.
Nothing comes without a price, but
right.
They said chemo.
Don't turn your back on the immune system. Once you start, it's not natural. Immunotherapy is not natural. If you take nothing else away, this is not what's supposed to happen. Dr. Pollack's supplements are natural. The exercise and diet are great. Immune checkpoint inhibitors are not.
Thank you very much. And so I think with that, we'll have to wrap up our session. Thank you again to Drs. Pollack, Rosenbaum, Wilky, and Van Tine for taking the time to be with us today and sharing your thoughts and expertise. We appreciate all that you do for the sarcoma community. And thank everyone who tuned in today to be part of this discussion. As a reminder, today's session was recorded, and a link will be posted to SFA's website within the next few days. You can find SFA online at www.curesarcoma.org. We have also posted information for future education sessions on our website. This now concludes the webinar.